So my name is Dr. Alon Orlev. As Dr. Litvak said, I'm his fellow, and I work under his guidance here at Swedish. I'm going to talk about what's new in surgery for glioma. There are a few topics, small topics that I'm going to talk about. None of them, as we can expect, solves cancer yet. I have no disclosures, and we're going to talk about two. The first two are going to be adjuncts that we have in surgery in order to help us get a better resection, do a better job, and I'll go into detail about both of them. The third one is a replacement to our conventional craniotomy. That's a lit, and the fourth one is an adjuvant therapy that we use in intraop, but it's part of the entire treatment that that the patients undergo or comes to replace possible post-op treatment. So the first one is the minimally invasive port-based surgery. So we have problems, surgical challenges with accessing deep lesions. Transparenchymal approaches have been quite devastating for patients. Classically, we've used PAL retractors, and that's been shown to cause quite a lot of flare damage and be clinically morbid on these patients. And in recent years, there has been quite a bit of development of minimally invasive tubular port systems, and they've been shown to cause less retraction trauma and allows us to access these deeper lesions. And so I'll show a little bit about these. There's growing experience. It started off by taking deep-seated hematomas out, spontaneous hematomas, and it expanded over the past few years to surgical resection of different lesions that are deep and difficult to access. There are really two systems that are the commercially available ones that are used. One is the NICO BrainPath, and the other one is the Vicor VBAS. There are other cost-effective systems that have been described by various people around the world, and I'll show an example of that. There are intraoperatively, these tubular retractors are advanced from the cortex to the target lesion using navigation, and we dock on the lesion, similarly to how we do a biopsy, but we have a bigger port that essentially allows us by manual microsurgical technique, which is the way we like to do surgery, having two hands, two instruments that we can suction and work within the cavity. So just some of the examples. On the left side, we see the Vicor system, which is oval. In the middle, we see the BrainPath, the NICO BrainPath, which you insert the entire thing, and then you take out the obturator, and you have the tubular retractor, which is the clear part. And on the right side, you have one of many that has been described that just very similar in size to the others. It's just a cut syringe with a centrifugal tube through it that has been used as well. This is from some of the experience of my mentor, Dr. Litvak. This is a deep-seated, very large occipital, temporal, and some parietal glioma that was resected using this approach through an occipital trajectory. And as you can see, once experienced, you're able to really resect it all through this tube. So there have been some reports about the experience with these. So Eichberg and colleagues in 2020 report on 113 intraparenchymal lesions of all type that were resected by several surgeons from a few centers, like 4 or 5 centers, using this tubular retractor, and they achieved gross total resection 72%, which is great, with new deficits in 10%. That about 4% of them were permanent on a 5-month follow-up. And Kai from Mayo Jacksonville reviewed 309 surgeries in 13 different articles over 10 years. And the most common lesion that was resected was glioma at 41%. And the most common tubular retractor, interestingly, was the modified type, similar to the one I showed on the right from the 3 of them. And gross total resection was achieved in 75% with a 9% complication rate. These are all good numbers. We have to remember a couple of things. First of all, that commonly these the lesions that are accessed are deep yet smaller, because very large lesions are, these are all lesions that were selected to be ones that you use a tubular retractor. These tubular retractors are limited in their size, and you're very limited in your manipulation that you do through the brain. So you don't go for very large lesions. So the 75% gross total resection is a great number. We have to remember that these are for selected patients. So next, I'll jump to the second adjunct that we have in surgery. It's fluorescence-guided surgery. That's been around. I'll talk about that for a bit. And as we know, there's distinguishing between pathologic and reactive cerebral tissue around the tumor is somewhat difficult. We don't have many good ways. We do it by the way it feels, by the way it looks, and the more experienced the surgeon, the less he needs adjuncts. I had the opportunity to train a little bit and watch someone who had probably done over 2,000 gliomas, and he just knew how they felt. And the rest of us would like to and are very much aided by markers of neoplastic tissue, and those have been developed over the past few years, and they've been around for a while. And using these markers, the extent of resection is enhanced, and there is a risk, and I'm going to go over that. I'll show you that as well. So 5-ALA is the one that's been used most. It's a hem biosynthesis metabolite that accumulates in glioma cells about 3 hours after oral intake, and that's what we do. We give these patients the morning of surgery, early in the morning. We let them drink it, and it emits this violet red fluorescence when excited by blue light. I'll show an example. I'll show a picture of that. It was approved in Europe in 2007, and then much later in the United States. There was a landmark study in 2006 that on 322 patients that showed great results. It showed that complete resection was achieved in 65% versus 36%, and progression-free survival was also enhanced greatly from 40 or 6 months progression-free from 41% to 21% for the patients that had 5-ALA used in their surgery. So that led to the European approval, and quite early on, there were numerous following studies that also showed higher rates of complete resection in glioblastoma and increasing progression-free survival, but it comes at a price, and I'll talk about that too. So this is from a paper, one of the papers that I'm referencing, and this is in A. We can see what the tumor looks like. So when you excite with blue light, you see this violet fluorescence image that the asterisk is where the tumor is, and you start resecting that, and that's all great because it lights up where the tumor is. Then once the tumor cavity is empty, or you've completed the resection of the enhancing area, then you get to B. And B is so the brain itself is blue, and what you see in violet color is area where there are potentially tumor cells that may not enhance on imaging, but these are tumor cells that with the uptake of this of the 5-ALA, and then you can continue resecting, and that leads me to, and we know these tumors are infiltrative, so that leads me to some of the criticism, and that is that the fluorescence never ends really, and the problem with these is that it has been shown that these patients have more neurologic post-op issues because of the extent of resection is larger, and understanding during surgery when to stop when you're actually exciting when you're looking at through this blue light, and you see that there's still fluorescence in the tissue well beyond where you intended initially to resect. So that's one criticism. The second one is that many people have been talking in recent years and previously about anatomic supramaximal resection, and that may be advantageous to understand the anatomy and the physiology of where you're working, to be aided by either having the patient awake or doing neuromonitoring, and to design your surgery not based on what enhances, but rather to create a supramaximal resection, knowing that you have a lesion that the intraaxial tumors are go way beyond the enhancing or what you see in the imaging. And getting the supramaximal resection has been shown, again, not using the fluorescence, has been shown to be effective in both overall and progression free by the people who choose to do that. Again, it has its limitations and also its risks. And lastly, the criticism is that the 5-ALA is less effective in low-grade gliomas. It doesn't shine as much, and that's where it counts, getting a complete or a supramaximal resection. Just briefly, there are a few other fluorescent systems or molecules. One is fluorescein sodium. It's an intravascular fluorophore. It's IV. It's given IV intra. It accumulates in glioblastoma cells due to breakdown of BBB, and it's less specific than 5-ALA because it accumulates in peritumoral edema as well, because we know that the edema is partially because of this breakdown. ICG, it's another intravascular that has that is very much used in cerebrovascular neurosurgery because it's because you can see the vessels very well. It has a second peak 24 hours after admission, and it's similarly because of vascular permeability. It will light the tumor cells, but also the peritumoral edema similarly, and it has some of the same problems. Recently, there's been tumor paint here out of Seattle. It's interestingly, it's extracted out of scorpion venom, and it binds to glial tumor cell surface. Low and high grade gliomas, there was a phase 1 study in 2019, and we're still waiting to see what this may give us. I'll continue and talk about LIT. So LIT, again, is we're switching gears a bit. This comes to replace our standard craniotomies in many ways. It's a laser interstitial thermal therapy. It's a minimally invasive stereotactic insertion of a probe that creates a thermal lesion. It's a laser probe creates a thermal lesion within the brain where you want it inside the tumor. There are two systems. They're Medtronic Visualase and Monteris Neuroblade. They're both MRI compatible cooled probes that have reproducible MRI thermometry, and we actually use the MRI in order to see what we do or how hot the area is, to both plan and also create the lesioning within the lesion. So the treatment steps are the trajectory from the skull to the lesion is planned similarly to the way we do a biopsy. A bolt is fixed into the skull at the entry point, and this is all done in the MRI room. The stereotactic needle is advanced through the bolt into the lesion. The laser probe is inserted into the needle, and then the laser is turned on and it's directional, and it creates it increases the local temperature inside the lesion, and over time you create this thermal injury of the lesion itself. So these are the two systems, the Medtronic and the Monteris, and again they're both used inside the MRI, and we can see in the Medtronic one there's a picture of the laser itself that is directional, and you turn that around and you create your the lesion that you want to create. So there's a little bit of experience in that, not much. In high-grade gliomas, it was mostly used for residual or recurrent small tumors, and that's important. You can't do it for very large tumors for similar reasons that we talked about, and also because the thermal injury can go beyond. So some have talked about less than 50 ml, others less than 35. And in high-grade gliomas, it's been used following other treatment modalities, again, commonly for recurrent gliomas. Small series of 10 and 4 patients with deep recurrent GBM that underwent LIT showed extent of survival, which was great, 9 to 11 months. We know that in recurrent GBM, we're talking about 3 to 5 months. So this is something that may be promising for these recurrent GBMs. Again, deep, small. Low-grade gliomas, it's again mostly deep-seated, less than 35 mLs. There were 18 studies on 98 patients with LGGs that underwent LIT as a single treatment. It seems to be well tolerated without permanent deficit, and the tumor sizes mostly remain stable, which is what we want it to look like once we lesion and heat it up. There isn't really yet true long-term data about progression-free and overall, just very, very initial ones. No clinical trials yet that have been published or long-term results, as I said. And the complications are seizures. That's not uncommon. Peritumoral edema and post-op transient deficit of around 5% permanent. Transient is more, 5% of it is permanent. Not very different than surgery, really. And my last topic in this talk is going to be about intraoperative brachytherapy. So brachytherapy is essentially, as we know, it's implantation of radioactive sources inside tumor cavity. It's been used for many different tumors, many different cancers, to reduce local recurrence. It has been tried in the CNS interestingly, since 1936, using the various radioactive isotopes that have been both minimally successful, and also there was a lot of issues of the radiation necrosis around that. So we've been honing in recent years to cesium-131. It's emerging as a promising isotope. For many reasons. One of them is that it has a half-life that is quite short, less than 10 days, which is much better than the next one, which is iodine, which has a 50 days, over 50 days, and it's been just safer to use. So gamma-tile, that's a product that's around. It's cesium radiation emitting seeds that are implanted in nice pliable tissue adherent collagen matrix tiles. It simplifies intraop placement. So once we finish resecting the tumor, we place these gamma-tile pads, which are a little less than an inch by inch each one. They're placed in a single layer inside the surgical cavity, following tumor resection. As I said, they deliver about 120 to 150 gray at the surface. Interestingly, they're not sitting while the gamma-tile sits on the surface. These the radiation emitting seeds are a few millimeters above the surface, which is safer. And at a depth of 5 millimeter from where they're placed, it's about 60 to 80 gray. They're approved for treatment for any newly diagnosed or recurrent malignant brain tumor. And where do they come into play? We don't really know yet. I'll talk about that in a second, but they may be designed to replace or augment post-surgical radiation therapy, which we know for high-grade gliomas, according to the STU protocol, we give 60 gray at 2 grays per day. There's a picture of what it looks like. The limitations, the implantation requires either gross or near total resection because, as I said, it doesn't penetrate very far. So if you have a multifocal or GBM, or you're just not resecting all of it, it won't be as good as post-op radiation because, again, it's just very local. And it may increase the rate of post-op infection, seizures, and radiation necrosis, peritumoral. We don't have enough data about that really yet. So there are ongoing clinical trials assessing the safety and outcomes. Interestingly, there was a study by Chen and colleague on 18 patients with GBM that were treated with resection, then gamma-tile, then post-op radiotherapy, and that was terminated due to high toxicity of 61%. And there are two other studies on 11 and 17 patients with GBM that were treated with resection and brachytherapy instead of the post-op radiation protocol. And those came to a progression-free survival of 7 to 10 months and overall survival of 9 to 16 months. You know, it's similar to what we know, right? These are not numbers that change GBM treatment, but it still has advantages. You don't have to bring the patient for 30 days in. It's something that ends intraoperatively by placing these pads that take a few more minutes. So it may have a role in the future, and it may replace post-op radiation to a certain degree. These are my references of the different studies for this talk, and I will gladly answer any questions.
Nice talk, Alon.
Thank you.
Yeah. I wonder whether there are a subset of patients you think that may benefit from ALA guided therapy surgery. I know you said low grade, it doesn't diffuse well, and high grade, it's all over. What about maybe anaplastics? There's less microvascular proliferation, or unifocal diseases. What's your thoughts?
So So it's commonly very much, it's used for GBMs when we think we have GBM, or when we don't really know. We like to use it when the tumor enhances. So that can be a grade 3 or a grade 4, because then we know it's going to, the chances of the uptake are high. And like any surgical tool, it's great, but you have to know your limitations. You have to understand where you are. And intra-op, you keep switching because you can't really do a lot of surgery under this blue light. So you switch to the blue light, you see where it shines. Sometimes it's very obvious because you're in the middle of the tumor, according to navigation, and then you don't need it. And then once you finish resecting the tumor and you have the cavity, then you start looking at this. You keep switching to this blue light, and when you see that it areas that it enhances, if it's areas that you're anatomically feel comfortable about resecting, it's worthwhile. The reason is because we have numerous papers that shows that we, by doing so, we extend their progression-free and overall survival. So it's a great tool, but you have to remember that it can be a dangerous tool if you just follow the shining light.
Yeah, I agree.
I would like to just add to that. Alon, good talk. Sorry, I had to step away for a minute to go down to see a patient, so I missed some of your talk. But I think 5-ALA is great in a certain sense. But you know, last year we had a talk by Sean Hervey-Jumper from UCSF, and he had this graph that shows, you know, between 20 and 80% of resection doesn't really impact overall survival for GBM. Anything above 80% does. You know, my question has always been, what, you know, is there good evidence that between 90% and 110%, like the Ray-Sawaya kind of super maximal data, does that really help a patient overall survival? And certainly I myself have had neurological deficits post-op, because you keep going after that red stuff, and then next thing you know, you've caused injury to the patient. So I think it's really one of these surgical judgment issues that you have to put all the factors together. What are you trying to accomplish? You know, how old is the patient? Is it a, you know, younger patient? I mean, you know, to some degree, like an 80-year-old with a giant multifocal GBM, you know, you're not going to try to cure the case by taking the tumor out. So I think it's just one of these things where it's really got to be individualized.
Yeah. I also want to throw one more thing in there. I'm not sure this has ever been validated, but the MD Anderson group, Dan Cahill also did analysis looking at extended resection as a function of IDH status, and, you know, made this observation that extended resection of enhancement was prognostic in the IDH wild type GBMs, but total extent resection, you know, especially non-enhancing, was important in the IDH mutants. And you know, so I think that sometimes comes into our estimation, you know, our analysis of benefit of additional surgery for patients when we see them and we have the pathology and we know which class they are, you know, sometimes going back for additional resection of non-enhancing disease in the IDH mutants. But, you know, if you get all the enhancement in a big, extensive GBM, maybe leave them alone.
Yeah.
Good point.
So I think that, as I said, for the low grade, which many of the IDH1 mutant are, that's where it really counts. And 5-ALA doesn't help you much because often these are not the ones that enhance, so they may not shine. Or you, many do give those, but you can't really count on that shining very well. So that's one of the main criticisms of this. And I don't know much about this, the very new tumor paint, but they seem to claim that it works also for low grade. So that may be a future promise.